Hello, everybody. I'm thankful to organizers of eHealth and to all the delegates who have come all the way till here to enlighten themselves on the latest issues involving the healthcare. And this particular session is mainly aimed at patient safety, satisfaction, and affordability. I think we have traveled from bad to good on this road, and now from good to great is a difficult path. And I believe the average concentration capacity of a human being is 30 minutes in any session. So I'm sure all of you must have far exceeded the limits of concentration. So I want to make it short and sweet, more interactive, and I start this session with a small note that, when you see the entertainment, it has come all the way from Royal Albert Hall to Amazon Prime. So I expect the same in healthcare. With this, I start this session. So, who would like to speak first? Believe me, I won't give you more than 2 minutes.
We're talking about affordability, accessibility in healthcare. I'd like to start off by saying that healthcare should be a right and not a luxury. And as a business owner, as a hospital owner, I'd like to say that we should not compete with five-star hotels, and we should compete and fight a battle against diseases. And bear in mind the cost of delivery and the affordability of the patient. And my main aim is to have, probably ask the government to have a regulatory body so we can regulate the prices and work with them, along with them, with dignity and respect, and get to a point where there is a threshold. We have to understand that. We have to understand there's a threshold for even the pricing. Just tackling the cost would not be sufficient. We have to even see the affordability of the patient. And just because we increase I've heard a lot of people say, increase your volumes, you can reduce the prices, but that doesn't really work. Just because you increase the volume of your patients, you can't really reduce the prices that much. So there has to be a threshold. There is a threshold, and we work towards that. We'll do our best, all of us together. I think we should be able to do our best.
That's great. That's great. Yeah, of course. Everybody has to.
That's why we're sitting on the panel. First off, thank you for inviting me here. I'm Dr. Tawseef, I'm the Medical Director of Premier Hospitals. Now, interestingly, the topic was patient safety, satisfaction and affordability. Now, when I looked at satisfaction and affordability, it seemed to go hand in hand, but why did safety crop up there? So I went and did some research, and Preeti was teasing me about why I have notes jotted down. So I did some research, and I found that the American Medical Association Journal of Ethics actually published some data in 2016, where they interestingly found the higher the cost to the patient, the more the satisfaction. The lesser the cost to the patient, the less the satisfaction. Very surprising. But more the satisfaction, less the safety, and vice versa. So very interesting study in the American Medical Association. Many factors that drive patients' perception of satisfaction. Affordability is always number one. Also how staff behaves with them, what is their access to service. But when we focus too much on patient satisfaction, sometimes we might go down on patient safety. For instance, a patient comes to us and says, they have a viral infection, the doctor knows, but they want antibiotics. Would you prescribe it to that patient? Maybe not. Will the patient be satisfied? Maybe not. Same thing. Supposing a patient is in pain in your emergency department, well, they may ask you for a narcotic, which again is a restricted drug. If you don't prescribe it, they're not going to be satisfied, but you are going to be doing the right thing for your patient. So there is a problem. Just coming down to affordability, what does it really mean? Is it affordability to the patient or affordability to the provider? Now, hospitals, time and again, studies have shown the best marker of ensuring patient safety and patient satisfaction is improving the nurse to patient ratio. And when you improve the nurse to patient ratio, you put in one nurse for many smaller number of patients, it increases the cost to the healthcare system. And this automatically gets translated to the patient. So if you want patient safety and satisfaction, the costs will go up. And this is the conundrum that most hospitals try to deal with. Today, the guiding principle is rather than patient satisfaction, it is about patient engagement, where the patient is actively involved in their own health care, where they say, okay, I know what my disease is, and I've been advised by my doctor or my hospital to take these steps. And then the satisfaction automatically improves, and also studies have shown the adherence to clinical care protocols by doctors also improves. So let's move from patient satisfaction to patient engagement. Thank you.
That's great. I think patient engagement will give the satisfaction a three-dimensional aspect. Thank you so much.
Thank you. I think our first two opening speakers have given a very good insight into what we are talking about today. I think the approach I would take is that we are all patients, we are all doctors. Most of us are self-treating ourselves and our families, and all of us are family members who are patients. So if we really put that at the center of the healthcare experience, everything will become well. Cost is important to us, quality is important to us, safety is important to us. So whatever we do in healthcare, if we position ourselves, our parents, in the middle of that experience, as owners or doctors or whatever your role is in healthcare, you will do a good job at it. Right now we try to, the model I try to give an example of is, I think that you all heard of Six Sigma, so 1 in a million defects. So healthcare, say in advanced economy, say United States or United Kingdom, is working at a 1 in a million error prevention. In India, for example, we are trying to prevent a 1 in 1,000 error. The cost of care comes in when you're trying to move from the 1 in 1,000 error prevention to 1 in a million error, because you need that many more safeguards, that many more regulations, that much more training. Fortunately, because of technology, we're able to leapfrog those immense barriers, and we're able to actually do things much more easily. You all heard of the, I'm a critical care and pulmonary specialist, and what I do is I do intensive care for patients. But even beyond that, I think critical care really means it's critical to care. If you can actually enhance the caring experience that a patient has, you can give better health care. I do what's called tele-intensive care. So at my hospital, what we do is we monitor patients remotely around the country. I also do that for the United States. Since I'm trained there, I'm actually monitoring the patients in the US. It's a night there, it's day here, so I'm actually doing ICU level care remotely. And technology allows you to do that anywhere in the world. Within India, we've been doing this for the last 5 years, where we are monitoring patients 24/7. And in critical care, some very cheap interventions actually save lives. In fact, simple things like giving IV fluids to somebody with low blood pressure with sepsis can improve mortality. Giving antibiotics, the correct antibiotics within 1 hour can improve mortality. These simple things actually are not well known. Despite the knowledge being out there for the last 20, 30 years, that knowledge has not gone there yet. So I think even having a simple connectivity with a two-way video conference and being able to tell patients out in the very rural areas where there's hardly one doctor out there managing the entire show, if we can advise them and watch their patients 24/7, it makes a difference. The last idea I want to leave you with is, you've all flown in aeroplanes. Many of you probably flew in a plane to get here. You did not know the pilot, you did not know the air traffic controller, you just knew that you got in, and got to your place fairly safely. And the aviation example of safety is what is being used in healthcare a lot nowadays. And it's a very apt example because just as in aviation, the critical nature of healthcare cannot be overstressed. And I think if we can use the same example, we should be able to make great inroads into healthcare. So I'll leave you with the parting thought that I think it's critical to care, and if you can put yourself at the center of the healthcare experience, all of the factors you're talking about, safety, satisfaction, affordability, will fall in place.
Thank you so much. You're in a niche area where the health cost goes up or goes down. And you play a very important role where compassion brings down the cost. One C brings down the other C. Don't you agree with me? Thank you so much.
Good afternoon. I'm Dr. Radhakrishna from Pratima. Hearing 4 speakers already, I would like to make a point slightly different. we are pure private players. We look at affordability right now differently. See, we cater to every kind of patient right now.
Little low.
Okay. We cater to every kind of patient right now. See, the patient payer profiles are changing right now. A lot of welfare schemes from the central government, state government, and all that, where the packages are very low, but still we cater to the patients. And we also address the patients who require or who want or who are looking at healthcare as an experience, not as a treatment. People are there who want everything to be a very good experience, even the healthcare. So looking at the affordability, I think part of the affordability is taken care by the government, part of the affordability is taken care by payers themselves. So if you don't attend to one of them, then we are doing some injustice to the society. So we need to attend to both of them. That's what is our take. And we cater to the patients irrespective of their paying method. We don't compromise on our quality, whether we are attending to the Argosy patient or whether we are attending to a deluxe patient. We never go down on our quality. So that's what I think makes the patient patient-centric. We don't really look at treatment separately from paying capacity of the patient. Paying capacity, as it increases, probably the experience changes for the patient, but not the treatment. So I think that's where we are looking at seriously. We always look at patient and doctor relationship will not be affected by what the patient pays or how it is paid. And for us, I think that is one of the important things to cater to every kind of patient, still give the quality. Thank you.
He gave a very clear message saying that, we as a private healthcare providers do take into account the affordability of the patient, but not compromised on quality. So the doctor remains the same, the food remains the same, the medicine remains the same. The only thing that changes is the ambience of the facility. That's what you mean, right? Yes. That's very loud and clear. Thank you.
I just want to touch upon a few things while my colleagues have already spoken. I would say that if we look the 3 points, safety, satisfaction and affordability. If you look from 3 angles or an outlook, from physical, people and processes, if you put in that way. What we are essentially looking at, like affordability from a physical processes, what we can do, whether you are having IT, reaching out different ways, infrastructure, so on and so forth. But from a people's point of view, what can be done, and from processes, what could be done. Let's take process. In the process, what we spoke just on the ICU model, understand we have the care pathways or the clinical pathways done properly in a way and getting documented. And if you go a bit deeper, we realize that we have data, but data is in manual format. And let's not look at these only the private healthcare, let's look at the public health system, with the district hospitals and resources. How much data is manual and how much data actually is getting translated into an electronic medical record or a system where it is entered. And then how much of the data is getting analyzed to actually really come to a conclusion. Are we giving a cost-effective treatment, a cost-effective protocol? These 2 things are missing pieces, which needs to be addressed on a larger platform and it needs to be done. Data is getting gathered, there are a lot of initiatives. It could be done both in public and private systems. But what we're missing is adoption of EMR is completely missing. Without that, we don't know which hospital is doing good. So we don't have a published data outcomes of quality today. So is cost. So a cost for doing a simple hernia may vary across the country, but what is the predefined cost? As I understand, I think recently in the last year, there's a publication of pricing study or cost study being done, I think at the level. If you look at, so cost versus outcomes, this is an important thing which needs to be done, and a platform, and obviously a body to recognize that. The other point is that we don't have outcomes monitoring. A hospital outcomes versus B hospital, public, private. We don't have outcomes monitoring, so that needs to be looked at. Third is that as we move forward, obviously there will be pressure on the healthcare systems in terms of delivering healthcare. Obviously we are saying it's not cost effective, but we are also looking at shared services models, okay, where hospitals will not be able to do each and everything. What would be done in-house versus out-house versus what could be a resource shared model like a tele-ICU. So we will see that a lot of shared service models coming up as we move forward because there's an increased pressure on cost. At the same time, if we take up our schemes have a lot of data in that in terms of what sort of treatments at what cost and so on and so forth. So if we understand that across nation, if we have this data analyzed, and we can always predict what could be the better way of dealing those things in each of the states. I touch upon service patient satisfaction a bit. Here, what we are looking at is how a patient will be satisfied. Again, we don't have metrics, measures done in public health system. While there are things on paper, we don't really know whether patient is really happy in a rural village to a rural hospital. Why? Independent in the private healthcare system, this is IP which is value adding in terms of integrating that pain areas within the hospital, how you can do a better customer care, how you can deal with it, and you have your own net promoter score and ratings which come up. Again, at the end of the day, we need to look at how the patient is really happy, the areas to really make them. So I think the home care services, the remote patient monitoring, all the things are the aspects which are going beyond hospital to ensure that the patient is really happy. But one of the critical things is the turnaround times within the patient satisfaction, which across all hospitals, including public health and nursing, it struggles on turnaround time, keeping the patient updated when will you receive your test, or so on and so forth, even when I'm not there. So if you have a lot of time getting wasted in terms of 2 days, like if you have to travel from X to 5 days, you spend a lot of time. So how do you cut down on that sort of waste of time and deliver what is really required to the patient? Now these are the things on turnaround time. Technology is making a difference. I'm sure technology will make a huge impact in creating patient satisfaction. On safety, I'll just address on safety. On the patient safety today, while physically we have safety in terms of equipment and other things, but if you look from the people processes, I think the nurses to others, what we are doing, like we are now trying to see nurse can take more load in terms of getting trained, can they do more pathways, more clinical things, can they document systematically, and what are things happening to them. So we see a lot of nurse practitioner programs, e-learning trainings happening to develop this field. So a lot of focus is on how to make a nurse-led model rather than a doctor-led model, because you have the nurses as a core work of people actually living here. So what can be done on that? And obviously in the processes, again, the clinical pathway is something that needs to be looked at.
I think we are a little bit time bound if you're not. Yeah, sure.
I just wanted to tell is that at the patient safety level, since we don't have the data being managed systematically in an EMR or systems, very few hospitals or systems do. So what happens if a patient comes back again and again? How much of your medical records department is digitized? How do you retrieve? How much process and protocol is there? So your health risk of that patient, how you minimize? Some of things to be looked at. Thank you.
Well said again, it is a
From a pediatrician's point of view, been in practice for 2 decades now. Health scenario has changed, healthcare has changed. Expectations have changed, partly because medicine has made some progress, and partly because Google has changed expectations of people, as now they know. Now, how do you manage health costs? health costs can be managed if there is a stratification of the caregiver. Now there is no stratification in 80% of the care given because 80% of the care is being provided by the private healthcare, 20% is by the government healthcare, which has a primary healthcare, a district hospital, and a referral center for the medical college. Does that happen in the private sector? No. But where is the care being delivered? Mostly 80% in the private hospitals. If there is no stratification, now in a small clinic, the patient has seen the bigger hospital, expects that ambience, you put in effort there, you increase the cost. But is it needed? The same delivery, which is simple, uncomplicated, will happen easily, costs, let's say, around 10,000 in a small hospital, costs around 50,000-60,000. I am not talking about the hospital making the tariff change. The insurance is making that tariff change. Why is it so? Okay, it is so. They can afford better healthcare, they have better standards, they can take care of more complicated cases. Then why are you saying this if the case is there? Make a stratification. Put it as level 1, level 2, level 3. Make the stratification the patients who need level 1, level 2, level 3, not based on their pocket, not based on their insurance, but their ability to deliver that care. That will bring down the cost, yes. Not this skewed system where you're paying the same amount at different levels for the same care, you're paying hugely different amounts, very, very hugely different amounts. Okay, what about the patient satisfaction? Why is he more satisfied? Obviously, when costs are very high, you get time to see a patient for a longer time. You can spend more time on a patient. You can spend more personal on the patient. Can you do that in a place where you are offering care at a cheaper level? Obviously, you can. So that also has to change. One of the major things that I have seen while recruiting youngsters or things that are happening is the level of education has changed so much that it is no longer uniform across medical colleges or across the institutions. You can get all kinds of training in the same college, various levels of. There is no baseline standard that we can be assured of. When this happens, the care that is offered to the patient also can be anything. There will be people who will miss a cataract in a newborn, there will be people who will miss a heart disease in a newborn, and there are people who will pick up a small speck of it. So why does this happen? No SOP, either when we are training them, or either in expecting an SOP from college which is doing the training. If it's not there, when will they learn it? They haven't learned it, they have come into life, they are not going to implement it. Is there a law that makes us follow SOPs? No, it doesn't exist. Is there a law that makes the cost rational? It doesn't. So the patient is very happy seeing a 5-star thing. I am aspirational. If Modi wants India to become US or whatever, why will I not? I am also aspirational. I have a small nursing home. I want to become something big tomorrow. So my aspirations, where does it start? Does it start with the care, which the patient is least aware of or least bothered about? Or should I start with the record? That is a difficult thing to answer. Let's not be hypocritical and say that all is rosy. It is not rosy. It is difficult out there. People are and have lost faith in the medical system, not because we are not delivering the right care, because it is so different in different places. So he is very confused. What is the right thing? Now, is a normal delivery where there is zero pain, absolute ambience, water delivery? Is that the right thing? Or is it Mukkama Mukku, Jor Lagao, Nikalo, Kya kar rahe ho? Is that the right thing? So now, what should he say yes to? Should he say yes to that simple mama or should he say yes to the giraffe? Now, you have confused him totally by giving different levels of care. You have not standardized them, you have not stratified them, neither the cost. So you have a chaos in the market. Nobody is sure what they have to do. Each one is following his path. Now that's where we are. There is a light at the end of the tunnel. Yes, we have to make ourselves SOPized. We have to put in those checks and balances. We have to clearly state what we are going to offer. No, I'm not offering you TPM. I'm not offering you INO. I will offer you this. This goes there. Now, when that happens, stratification will happen, and then the numbers will become better for each of us because I'm able to take care of a clinic. You will not see a clinic in a tertiary. So my patients are there. You are willing to see the tertiary care. This patient goes there. Your tertiary care is good. Now, I will do IOP. I will do tertiary care. I will do some of this care. Nobody's numbers are fulfilled. Nobody is happy. And then everybody is trying to do a bit of everything. How can safety be there? Can't be.
Here I would like to say that, family healthcare units will never go out of business. Whatever said and done, the costs involved in a tertiary healthcare are too high. Over a period of time, people will realize, and in US they have already realized. Okay, I spent 17 years of my life abroad, so I know how people are afraid to go to any tertiary care unit. Okay, and ultimately it is the health insurance companies that are dictating the health costs, not even the hospitals. And that time is very short where we also get dictated by the insurance companies. Overall, I would like to close this session saying that, medical profession has moved from a noble profession to a service industry. Do you all agree with me? It has moved from a noble profession to a service industry. Now a time has come. This service industry is moving towards an experience industry. Patient is not bothered what service you give. Okay? He carries an experience and that worries you. If he carries a good experience, he's your fan. And if he carries a bad experience, he becomes a villain to you. So we are more into an experience industry. Wake up to that reality. We are no more in service industry. So we are getting closer to entertainment industry. That's a fact. Thank you so much.